the light. Okay, good afternoon, everyone. My name is Jean-Lue OUHIOUN, and today I'm going to talk to you about transverse dimension and bioprogressive philosophy. First, thank you for welcoming me to the Symposium of the Modern Bioprogressive. I am particularly happy to be here in New Orleans, all the more so that I am French. Second, I would like to thank everyone involved in the organization of this wonderful symposium. Thank you, Nelson. I am an orthodontist in Lyon, the third city in France. It's a city which is both proud of its heritage and modern. It's a city famous in the whole world thanks to the Lights Festival, which lasts for 4 days in December and which draws 4 million visitors every year. Lyon is also the capital city of the cinema. The Lumière brothers invented the cinema there. It's also the world's capital city of gastronomy. If you ever come to France, I strongly recommend you stop by Lyon. I would also like to thank my masters, Dr. Ricketts, without whom we wouldn't be here today, and of course, Dr. Carbuggino. I think he allows me to call him my friend Carl. Thank you, Carl. I am lucky to have been working with him for almost 20 years, and with my other friends, Dr. Delamer, who unfortunately passed away recently and who we really miss, and Dr. Froger, who is an orthodontist in Paris. I've always been attracted to the bioprogressive concept because it was not only an orthodontic technique. It is first and foremost a way of thinking which enables us to consider the patient as a whole entity and not just as a pair of arches. The principle is to first diagnose, then to determine our objectives, and finally to treat. Indeed, when a 20-year-old young lady comes to your office, after 2 years of treatment, 4 extractions, a face showing dysfunctions, and who complains that she has trouble sleeping and that the aesthetic of her face and of her smile is a problem, obviously you think a diagnosis hasn't been made. She shows a backward mandible, a class 2, a maxillary and mandibular ambiguity, and a light clouding. We must do everything all over again. Here's another patient. She is 32 years old and complains of cervicalitis, of TMJ problems, of having trouble sleeping with oral breathing, and a dysfunction of the tongue. 30 months of treatment and 4 extractions for this result. The cause has not been treated. You can see a V-shaped maxillary, the relapse of the anterior open bite, and the non-correction of the maxillary ambiguity. Here is an 18-year-old lady, probably treated without diagnosis. Her functions are very disrupted, and her profile is butchered. What about this young lady treated with 4 extractions in adulthood, who tried to solve her aesthetic problem with veneers on the 6 anterior maxillary teeth? However, she now wants to solve a functional problem, which is a consequence of her non-corrected maxillary and mandibulary endogenesis. And how is it possible to assert that extractions prevent the relapse of dental closing? All these patients had to undergo a new treatment combining orthodontics and surgery. When we see things like this, we must ask a number of questions. Didn't extractions make functional problem worse? Was a precise diagnosis made? Obviously, all these cases happen because functional and transverse problems were not taken into account. It is thus necessary to have a global vision, to think beyond the teeth in order to be able to develop a quadridimensional perception of the patient. It is the reason why Carl Gugino has developed this notion of 4D spatial functional model, which takes into account the 3 senses of space, but also time and the patient's dynamics. My demonstration will unfold into 2 parts. First, I will analyze the transverse dimension of the diagnosis as I look for the causes of dysfunctions. Second, I will deal with the therapeutic means. Everything starts with a clinical examination as we look for the causes of the perturbation of the transverse dimension. This moment is ideal since it is the only moment when we perceive the dynamics of the patient and his or her behavior. Since most we know that the position, the growth, and the shape of each bone depend on functional matrices and muscular behavior. For example, have a look at these retial cranial deformations from Africa. The face is going to be especially responsive to functional problems because of the numerous functions it shows. Seeing, hearing, smelling, phonation, mimicry and smiling, nutrition with chewing and swallowing, breathing, which is inseparable from swallowing, as we shall see later on. All these functions will influence the posture of the lips, of the tongue, of the mandible, of the head, and of the body in general. For these reasons, many dysfunctions, isolated or not, may be found on the face. Many power functions may also be found, for example, suction. To this, we must add growth, which is the first element of the time factor, which may amplify the dysmorphism. The time factor may also influence the action of the dysfunctions. Everything will depend on the age when the dysfunction appeared. If we compare it to the age of the patient, we will know for how long it has disrupted the morphology and growth of the face, and its early occurrences. Harvard had shown the morphological adaptability of the face and its vulnerability in monkeys. The girl at the top, her mandible hasn't grown forward at all. As far as the boy goes, his facial growth took place almost only vertically. And the maxillary of the young girl in class 3 at the bottom of the screen has not grown forward. During the clinical examination, we will observe breathing, muscles, posture, and habits. First, breathing. It must be considered as inseparable from swallowing. Indeed, for nasal breathing to happen, swallowing must be of the secondary type, which implies a high tongue posture in the mouth and closed lips without tension at rest. Of course, we may have cases of macroglossy, but it remains exceptional. Here are the main signs which can enable us to detect oral breathing aside from anamnesis. The width of the nostrils and of the columella, the presence of dark circles, interlabial gap, which is a pathognomonic of oral breathing, the appearance of the lips, chapped, dry, scale deposit on the lingual face of mandibular incisors, which proves a low posture of the tongue and an accumulation of saliva in the zone. All these signs should warn us against the possibility of oral breathing. Breathing, and this is probably the most important thing, must also be nasal during sleep. It is not necessary for the child to be snoring for us to think there is oral breathing. Also, the position in which he or she sleeps can be the cause of a problem of posture. It is fundamental that breathing be nasal. Why is that? Because it comes with a balanced musculature behavior, with the tongue in a high position, which will help the transverse development of dental arches and of bone bases. When breathing is oral, the muscular behavior changes, the mouth opens, putting the lowering muscles in tension, and the tongue lowers in either anterior or posterior position. And this will have morphological consequences. First, we shall make sure the airways are not obstructed. To do that, we must examine tonsils and adenoids, look for nasal septal deformities or turbinate hypertrophies, and the existence of allergies. In all these cases, we shall address the patient to an ENT specialist. But most of the time, oral breathing is behavioral and not the consequence of an obstruction. It will then be corrected by functional training like other bad habits. Now, just a few words on posture to understand the correlation between breathing and posture. A balanced posture implies an orthostatic position of the head and the neck. The different planes are horizontal and parallel, especially the Frankfurt plane and the scapular plane. In case of oral breathing, the child, to optimize the mechanical behavior of the pharynx, will accentuate his cervical lordosis by shortening the cervical muscles, which explains a number of cervicalgias. It is a typically adaptive posture to a restriction of airways. Have a look at the posture of the child and his cervical hyperlordosis, which is also visible on the lateral X-ray, which accounts for the transverse constraint placed on the dental arches and for an anterior open bite. The interposition of the tongue is probably secondary to the open bite and not its cause. With the worsening of the oral breathing and the posture, the head rises more and more, and the child no longer sees what is in front of him. It is a typical posture of these children with permanent oral breathing. That is the disappearing of the cervical lordosis, the presence of the rectitude of the cervical spine, the importance of the backward mandible, and the transverse constraints against arches. We are now going to tackle the question of the muscles and their influence on growth and facial morphology. The face is composed of complex and important muscles. We shall always keep in mind the picture on the right. It's a view from inside the mouth. It is easy to understand that the teeth will undergo the pressure of this intense musculature forward and of the tongue behind. And this will determine our position in space. When we talk about musculature, and especially here in New Orleans, we must remember the late Dr. Sidney Frederick. Thanks to Carl Gugino, we had the chance to meet him in 1992 in Sarasota, and it took our breath away when he introduced his work on the buccinator. I keep the memory of a brilliant and discreet man who was proud of his French origins. He showed us how the buccinator places constraints on the development of the mandible. On this picture, when we see an important white line of the, and an undulation of the alveolar process and an abnormal visibility of the dental roots, we are sure to be in presence of a powerful buccinator, especially its lower bound. Now, here is a case of this young 7-year-old boy with a powerful buccinator and a functional sublabial furrow. We started the treatment with a surgical weakening of the buccinator, and the results we obtained after 6 months with functional training, but without mechanical treatment, were very interesting. You can see the various modifications on the profile and the tensions, the bettering of the overjet, the modifications of the shapes of the arches and again the overjet, and the changes on the X-rays. Now let's develop a few ideas on the facial growth and morphology. In the fetus, everyone agrees to say that blood circulations play a morphogenetic part in the cardiovascular system, and that the cerebrospinal fluid plays the same part in the cerebrospinal system. Well, there is such a thing as fetal breathing. It is a real breathing phenomenon, since we can observe the circulation of the amniotic fluid through the upper airways. These pictures in color Doppler echographies from front and side views by Claude Talmont clearly show that the amniotic fluid passes through the nostrils back and forth, proving that the fetus is actually inhaling and exhaling. Facial morphology does start to shape itself as soon as intrauterine life starts. From birth, the skull of the baby possesses certain characteristics, such as the absence of basic cranial flexion, and an obliquity of the pterygoid bone. The pharynx is very short, about 4 centimeters. There is no oropharynx, and the epiglottis is in contact with the soft palate. The tongue is entirely intraoral, and the hyoid bone is as level C1, C2. The neonatal pharynx has really been conceived to resist collapsus. It is very interesting because it enables to separate air and food ways. No wrong way is possible. This will enable the baby to keep breathing through the nose while it is breastfeeding. However, it is going to learn oral breathing very quickly, for instance, when it cries, when the soft palate rises and presses against the posterior pharyngeal wall, or when the first infectious problem of the ENT sphere appears. After birth, the growth in depth of the pharynx is very low, about 9% of its initial size. It is also very limited in width, since it reaches the quasi-totality of the adult width by the age of 3. Its axial growth is very different. The height of the pharynx will go in average from 4 to 13 centimeters. If we consider the pharynx as an elastic cylinder, we know that a cylinder is all the more deformable as it is long compared to its radius. Hence, as it is growing up, the child will have to implement a control mechanism of its pharyngeal light in order to resist the mechanical instability resulting from it. Oral breathing becomes possible thanks to the crossing of the nasal and buccal ways. We've just seen that during the growth of the child, the epiglottis will progressively withdraw from the soft palate, making oral breathing possible. We will have the impression that the hyoid bone will descend during the growth. Actually, its vertical ascension is not as quick as that of the cervical spine, and it will progressively end up at the level C3, C4. This ascension is more or less slowed down and depends on the intensity of the traction of the cervico-thoracic visceral chain in connection to the type of breathing. In the brachyfacial, the axial growth of the cervical spine is moderate, and the hyoid bone will keep the same axial level. In the dolichofacial, everything is different. The hyoid bone will stay down, all the more so that the vertical growth of the mandibular ramus will be low. This kind of situation is very common among patients with apnea. These patients permanently breathes through his mouth and notice his very important contraction of the chin due to his interlabial gap. You can observe the inclination of his cervical spine in order to compensate the mechanical obstruction of his oropharynx. The hyoid bone is very low, and the base of the tongue is lifted up at the back, provoking a shrinking of the depth of the pharyngeal light. The cephalometric measures between the soft palate and the posterior pharyngeal wall, and between the base of the tongue and the posterior pharyngeal wall are greatly diminished. This 15-year-old girl was diagnosed with a severe syndrome of obstructive apnea of the sleep. You can observe the low depth of the oropharynx and the low position of the hyoid bone. Here is another example of low pharyngeal depth. Since Jean-Lue and Van der Linden, we know that in the 25-week-old human fetus, the width of the inferior part of the piriform orifice is equal to that of the crypt of the central deciduous upper incisors. This is also true at the age of 1, at the age of 5, and 8. The room available for the maxillary incisors and the intercanine intestines depends on the width of the base of the piriform orifice. This means that when we observe a maxillary incisive closing, we can infer that the base of the piriform orifice is narrow and that the performance of the breathing is also low. If we take into account the law of Poiseuille, we know that the volume of a flux circulating through a cylinder is proportional to the force power of its radius. As you can see here, when the radius of a cylinder goes from 1 to 1.2, the volume of the flux doubles. If we apply this observation to the nasal fossa, like we would in case of maxillary disjunction, we understand right away that the breathing will get a bit better. We end up with a cybernetic loop, morphological change, airway obstruction, neuromuscular feedback, postural change, stretching of soft tissues, differential forces of the skeleton, morphological change, airway obstruction, etc. Where do we locate the entry? I hope we are agree on the fact that the beginning of the loop is the obstructions of the airway. To put it differently, any patient carrying a malocclusion presents a certain degree of dysfunction. Now, let's study what's going on inside the mouth. The first thing to shake is the shape of the maxillary. You want to look for a V-shaped maxillary. Because when we have a disrupted shape of the maxillary arch, there is a perturbation of the occlusion and of the maxillomandibular relation, with posterior unilateral or bilateral frostbite. This may provoke a deviation of the dental midlines, which will need a differential diagnosis. In order to do this, study models have to be mounted on an articulator. Then we will have to measure the distance between canines on the frontal X-ray when the patient still has his deciduous or mixed denture, and on the models when he has his permanent teeth. Indeed, we know, thanks to the study of Samir Bishara and Cole, that in class 2 division 1, there is almost always a diminution of the intermolar distance, whatever the stage of the development may be. Anteroposterior problems are always preceded by a transverse problem. Another conclusion of the study is that the transverse discrepancy did not seem to self-correct during the passing from the deciduous to the permanent dentitions. We will observe the distal vestibular rotation of the molars, which is a factor of the locking of the mandible in the transverse direction. And finally, we would choose the diagnostic arch form. To do that, we use a pentamorphic arch selector, such as Ricketts defined: narrow ovoid, narrow tapered, normal, ovoid, tapered. The continuous line is placed on the point of cuspids, and the stippled line represents the slope of braces. Of course, we have to choose the arch form in regard to the mandibulary arch. Actually, we must look for the shape which is close to the initial shape of the mandible. In general, there will be a high correlation between two types of forms, and it will be our job to choose the most adapted one. In this example, we will probably choose the narrow ovoid form. This brings us to the subject of the looking of the growth of the mandible in the transverse directions. It is important because the locked denture will affect the growth of the TMJ and thus induce potential dysfunctions. The first situation is a molar fulcrum consecutive to a distal vestibular rotation of maxillary molars. The other two situations of looking are the V-shaped maxillary and transverse constraints on the denture. Two situations exist. An alveolar constraint, as you can see on the picture at the top, with alveolar maxillary processes going down and inwards, and mandibular alveolar processes going up and inwards, which gives an arches the characteristic shape of a diabolo. And a maxillary deficiency with alveolar maxillary processes that are relatively vertical. We will only superficially tackle the subject of facial asymmetries, which find a surgical solution most of the time, as you can see on the pictures. Initial findings. Do not expect a significant improvement of the crowding in the incisive sector after the eruption of the lateral incisors. The incisive crowding has a great symptomatic value, but we may still wonder whether this is a real problem. See how the insufficiency of the dental support harms the mode of functioning of the facial envelope. The correction of the anterior upper crowding is inseparable from the orthopedic or surgical correction of the transverse shrinkage of the piriform orifice. It follows that you should never wait to treat a dysfunction. You should never treat a dysfunction separately. Handling a lingual dysfunction alone, without handling at the same time the other dysfunctions, in particular oral breathing, and the skeletal anomalies, very frequently leads to failures. It needs of a global care. The fact that hypertrophies, even important ones, adenoid vegetations, and tonsils are usually consequences of the velopharyngeal tongue hypotony and not the cause of the oral breathing. The removal is not always indicated, thus their regression can be obtained by a good velopharyngeal physiotherapy. Thus we should treat as soon as possible, and the most completely possible, all the orofacial and cervical dysfunctions. and all the skeletal anomalies that can both normalize the craniofacial construction. What can cephalometry bring us? Today still, most diagnoses are bidirectional with panoramic and lateral X-rays. While we need a tridimensional diagnosis and thus a frontal X-rays. The frontal cephalometric tracing is simple, much more so than the lateral one. The landmarks used in the frontal analysis are few: 5 right marks and 5 left marks, and that's all. The frontal analysis can be narrowed down to 4 measures: the parallelism of the plane of occlusion to the Z-plane and the zygomatic plane, the width of the nasal cavity, the right and left maxillomandibular relation, and the distance between the lower molar and the frontal denture plane. These 4 measures suffice to have a precise opinion of the face of the patient. To be more precise in our description, we could also take into consideration the facial width, the maxillary width, and the mandibular width. We can thus complete our diagnosis by talking about a maxillary deficiency, a mandibular deficiency, or both, which can be either minor or major. Nowadays, with the cone beam techniques, looking for anatomical structures and analyzing the face have become amazingly simple. I own in my office a large field cone beam, computer tomography, and I enjoy it. As far as aesthetics is concerned, the transverse dimension plays a great part. Most patients come to us with aesthetic concerns, and we must answer to their demands. And the first question